In this video recording, I'll be sharing the African Head and Neck Society resource appropriate head and neck cancer guidelines with you. Head and neck cancer is primarily a lower and middle income country problem. It accounts for 70% of head and neck cancers, 80% of head and neck cancer deaths, and patients present with advanced cancers. And the modern diagnostic and therapeutic tools available to high-income countries simply aren't available in most low and middle-income countries. And the vast majority of patients in the world who are in low middle-income countries do not have access to timely, safe, affordable surgery. And similarly, all the areas in the world circle there, patients have poor access to radiotherapy. And for those patients that need to be palliated, in 66% of the global population in 2014, virtually no patients had access. So lower middle income countries, which account for 80% of the world's population and patients, have poor access to surgery, technology, radiation, and palliation for managing cancers. And because of these constraints, head and neck cancers are treated differently due to the unavailability or unaffordability to the patient of special investigations, of radiotherapy, of surgery, and the management of sequelae of treatment. Therefore, international clinical practice guidelines for high-income countries such as those of the NCCN are often unhelpful, they're often inappropriate, and can even be harmful if they're applied in low-resource settings. And therefore, the gold standard of head and neck cancer care, when you look at head and neck cancer management globally, is not what is offered in high-income countries, but is really providing optimal care with available resources. And that might be determined by the income status of the country or the healthcare system or the patient, the availability of radiotherapy, and the availability of surgical expertise. The African Head and Neck Society has promulgated clinical practice guidelines for head and neck cancers in developing countries and limited resource settings, which I'd like to share with you. And the reason that these have been developed is that high-income country guidelines such as the NCCN are often inappropriate. An example would be the management of a nodule of the thyroid. The first test that you would do is a TSH, but that might not be available to your patient. Then you would proceed to a high-quality ultrasound of the thyroid and the neck, and that might not be available. And then you would proceed to fine needle aspiration, ideally under ultrasound guidance, and that might not be available or of good quality. And some patients may require radioactive iodine imaging, which also might not be available. So if you have missing elements in this algorithm, how do you apply it in your low resource setting? Similarly, if you have a papillary carcinoma, you would start by doing an ultrasound of the thyroid and the neck. You would follow that with ultrasound-guided fine needle aspiration cytology. And the minimum procedure would be a thyroid lobectomy or a total thyroidectomy. And some patients may require radioactive iodine therapy. Now, once again, if some of these elements are missing, how do you apply this guideline in your resource constrained setting? So international thyroid guidelines assume the availability of TSH, ultrasound, cytology, thyroid scan, and radioactive iodine therapy. And they also assume that patients can be monitored and have the thyroid and calcium deficits replaced. They do not cater for limited investigations and treatment and for managing surgical sequelae, such as hypothyroidism, which occurs in 25% of patients undergoing thyroid lobectomy, and hypocalcemia in 5% of patients undergoing total thyroidectomy. So the African Head and Neck Society has developed these guidelines, which you can find at their website. And to show you how it works for thyroid nodules, there are 16 management algorithms based on the availability of ultrasound, TSH, thyroid scan, and cytology to evaluate a thyroid nodule or a mass. If you have them all available, then you click on number 1. And that takes you to an algorithm which is similar to the NCCN guidelines. If you have a situation where you do not have good ultrasound or cytology, then you click on number 8. That takes you to an entirely different algorithm. And if you're dealing with a papillary carcinoma, then there are 8 different management algorithms depending on the availability of thyroid monitoring and replacement following surgery, calcium monitoring and replacement, and radioactive iodine therapy. If you have them all available, you click on number 1. And that takes you to an algorithm which would be similar to the NCCN. If you have a situation where a patient is from a rural area and will not present for follow-up, you click on number 8. And that takes you to an entirely different algorithm, which includes simply excising the thyroid nodule or doing a subtotal thyroidectomy to preserve thyroid and calcium function. And another example would be that of parotid tumors and cancers. And here there are 16 management algorithms based on the availability of cytology, CT and MRI, total parotidectomy expertise, and radiotherapy. So if you have them all available, then that's the algorithm which one would apply. And if you do not have CT imaging, that's the algorithm. And then if you do not have total parotidectomy expertise or radiotherapy, it's a different algorithm. And once again, if you only have radiotherapy, that's yet again a different algorithm. And if you go to the website, you will find that we've done the same for all the common head and neck cancer sites. So really, the gold standard of head and neck cancer care is not what's necessarily done in high-income countries, but is providing optimal care with available resources. That will depend on income, or radiotherapy availability, and surgical expertise. And what the African Head and Neck Society guidelines for head and neck cancers does is it tailors the care according to resources available to the patient and the treatment center. I believe the Global South is best qualified to write the guidelines as we best understand the challenges, constraints, and possibilities. And the Global South is taking ownership and leadership and responsibility for how we manage patients in lower and middle income countries. And I invite you to visit the African Head and Neck Society Resource Appropriate Guidelines at afhns.org or developingworldheadandneckcancerguidelines.com.